देख लेंगे।
Hi, good evening, everyone. Respected Dr. Tanushree Saxena, ma'am, esteemed members of IADP, and dear doctors. It gives me immense pleasure to welcome you all to yet another enriching episode of Learn from Our Master series organized by International Association for Dental Practice Excellence. Crossing 90 successful webinars has truly been an incredible milestone for us. This journey has been possible only because of your constant support, active participation, and the overwhelming encouragement we receive. We are truly humbled and grateful. For those who are joining us for the first time today, a brief introduction. IITP is a dedicated academic platform built on the behalf that quality education leads to predictable and confident clinical outcomes. Dentistry is ever evolving and technique sensitive, and continuous learning is essential to stay ahead. Through our webinars and workshops, we aim to empower dentists across all disciplines and practical knowledge and real world clinical insights. So, I would like to introduce today's session. Today's topic is simplifying complex retreatment, real world clinical tips and cases. And we are privileged to have with us an accomplished endodontist, Dr. Tanushree Saxena. Dr. Tanushree is a practicing endodontist and an alumni of Savita Dental College and Hospitals, Chennai, where she completed her postgraduate training in conservative dentistry and endodontics. She specializes in complex endodontic procedures under magnification, including management of missed canals, calcifications, and instrument retrieval. She is currently pursuing an integrated PhD and has received multiple awards at national endodontic conferences, including Best Patent for her work in instrument retrieval. Her dedication to clinical research, innovation, and case based education makes her the perfect mentor for today's session. Without further delay, it is my honor to invite Dr. Tanushree Saxena, ma'am, to take over today's session. Ma'am, please.
Thanks a lot, Dr. Juna. Hello, everyone. I'm Dr. Tanushi Saxena. Thanks for the warm introduction. I just want to confirm whether all of you can see my screen and whether Is it on presenter mode or you can see the full screen so that we can go ahead? Can anyone confirm?
Yes, ma'am.
Okay. So this is, you can see my full screen, right? The full presentation?
Yes, ma'am.
Full screen.
Okay, okay. So let's start here.
It
So,
is on
as
presenter mode.
yeah, that's why I was just confirming. Let me just change this. Uh, okay, is it all right now?
Yes,
Yes, ma'am.
doctor.
Okay, once again, good evening, everyone. Today's topic that we are discussing here is simplifying complex retreatment. I am an MDS from Savita Dental College. I recently graduated in November 2025. I'm currently working as a consultant endodontist in Paras hospitals here in Gurgaon. So, what are the topics that we are discussing today? Basically, we'll be going ahead with what is failure in endo, trying to define it, how do we gain access during retreatment, intercanal obstructions, the removal of root canal fillings, and then we'll briefly also talk about the disinfection protocols. Yes, so starting with what is failure in endodontics. So we all know endodontic disease is basically a microbial pathology. There may be mechanical deficiencies, there may be missed canals, ledges, perforations, but ultimately everything leads to a microbial disease. Coming to the microbiology of post-treatment disease, that is what we call endodontic failures. When there is a persistence of microorganisms in the root canal system, there is acute symptoms can occur to the patient. That includes, they can have pain during tendon. You can have tenderness on percussion. They can have pain. So a lot of it is a microbial pathology. It mostly is an intraradicular infection. It can also be extraradicular. Very rarely is a foreign body reaction to any of the root canal filling materials or anything we use. So coming to apical cyst and true cyst. So we need to understand that the difference between that so that we understand that when it is a true cyst, that means there is it is divided from the root canal with an epithelial lining. So even if we do nice intraradicular disinfection, we may not be able to subside that infection. That might need a surgical option. So this presentation is basically on non-surgical retreatment. Now, coming on whether radiographic failure is equal to clinical failure. So, no, we can have asymptomatic radiolucencies. Every one of you, I think, must have heard of apical scars. So, a scar tissue can also appear radiolucent. And also it might not be in the state of active disease. So, whether should we treat every radiolucency and retreat the tooth? So, that's not an answer that we just come across with just radiographs. We have to look at the clinical symptoms also. Then if we compare, should we retreat everything we can? So it depends upon the strategic value of the tooth, the periodontal support, how much is the remaining dental thickness, and the ferrule consideration, so that there is an overall, the prognosis of the tooth is good. I'll just take 1 second. Yeah, I'm sorry for the delay. I was just figuring out the presenter mode. Okay. So we can see here in the picture. So the clinical presentation of a tooth which has a persistent periapical disease, we can see the debris as well as the secondary caries. So this again indicates that root canal. Hello. Yeah. So root canal retreatment is a microbial pathology of periapical origin. Then, so European Society of Odontology has given two indications basically. Whether teeth have inadequate root canal filling, you go for retreatment, and if teeth have inadequate root canal filling, and also they have to go for a new coronal restoration or a new crown. So again, this limits the definition for retreatment basically. So Carr has proposed an updated definition which says that it is a procedure performed on a tooth that underwent a previous attempt at definitive treatment that resulted in a condition requiring further endodontic intervention. So now let's talk about gaining access. So the first procedure, the first phase of retreatment is gaining access to the root canal. This includes removing old restorations and also removing intracanal obstructions, which include your pores. It can be the paste that we use, hard cements, etc. So why access in retreatment is different is what we are coming at. So there are certain reasons. We have existing direct or indirect restorations. We may have post and cores. Then there can be iatrogenic complications from prior treatment. There can be poorly made access cavity. They can be, because of that, there cannot be a full, exposure of the pulp chamber. They might not be proper deroofing, etc. So if we do not modify the access, we can have suboptimal biological outcomes. So they can be missed canals, perforations. We can have incorrect angulations of our files, inadequate cleaning, and then again reinfection. Also, in anterior teeth, we need to consider an aesthetic factor. So if we have root canal filling GP extending into the above the CEJ, we may have discoloration in the future. So we need to have a good preoperative assessment. Information from radiographs, what we can assess while looking at the radiograph, we can see the long axis of the tooth, even if it is covered by a crown. We can see what is the crown root relationship exactly, uh, how much is the length of the root, and then what is the post type, what is the angulation of the access cavity, what is the remaining amount of pulpal for thickness. You can't see that when there is a crown of course. Then when there, what are the information from clinical examination that we can gain? So we need to check the periodontal status, whether there is any pockets, sinuses, and then furcation involvement. We have to see what kind of restoration is underneath the crown once we remove the crown. Then what is the adjacent tooth relationship, whether there are open contacts and whether there is a supra erupted tooth, anything like that. Then what is the core material characteristics? And then finally, some history, maybe we can, if we are in contact with the previous clinician, or if it is a case referred to us, then maybe we can know what type of pores, what type of cement, or whether the crown was a single unit or conjoint. You can see that on radiograph as well. So should existing restorations be removed routinely? This is a question that is hot topic which we need to know. So the evidence that is there strongly recommends removal and then replacement. Why? In this picture, you can see an access opening in an incisor. You can see where after doing an enlarged access opening through the crown, we can see the long axis of the tooth. So once there is this condition, there can be increased chances of perforation. We don't know what is the axis of the tooth underneath the crown, basically. Other than that, once we remove the filling, we can also identify cracks within the structure. So that is why removal of crown restores a diagnostic clarity. It reduces iatrogenic risk. So coming to removal of coronal restorations, first we'll talk about direct restoration. Suppose there isn't a crown on the tooth. So again, we have to use magnification illumination. If it is a composite restoration, we can use air drying alcohol rinse. We can contrast between an hydrated dentin and the resin. Now, these restorations usually discolor over time. We can easily make out them from the margins. We can make it out. If they are new, we can use DG16. We can scratch the composite. There will be a gray or black line on it. And natural tooth won't have that. We can acid etch. Enamel will appear frosty white. Composite will remain smooth and glossy. And then again, transillumination. And then we can assess in the radiograph the depth of the restoration. So usually we have a stepwise removal strategy when we are looking at posterior teeth. So once we are gaining access, we should remove a bulk removal from the lateral side, but the floor of the pulp at the pulp chamber, we should at least have a 1 mm of composite remaining. This we should try to remove with ultrasonics because this can lead to perforations, iatrogenic perforations, and also we can lose the pulpal floor anatomy, the landmarks, which may lead us to additional canals and all those cues we can miss. Also, there is unnecessary removal of sound dentine if we use rotary those burrs, diamond burrs, and this we know about the concept of pericervical dentine and how important it is. We can perform pre-endo buildup that will give us a good four-walled access, and we can have effective isolation during the root canal and then effective irrigation as well. So this was regarding composites. Now, when we talk about amalgam, if there is an amalgam restoration during retreatment, so usually tungsten carbide burrs are available. You should insert this burr between the tooth and the restoration interface, and often it will be removed as a single piece or like bulk of 2-3 pieces. So now there may be some situations where amalgam extends below the orifice or into the canal. So they have those Nair cores we call that extend into the canal. So for that again, rotary burrs are contraindicated. We can use ultrasonic tips for them. I will let you know what kind of tips we can use. Then we can prevent because of this, because if we use burrs, we can actually, it can slip and we can go for false paths and grooves we can create. So that's why that we should avoid. So again, for anterior retreatment, what consideration, as I spoke about this, sealer pigments and gutta perca, if it is present in the pulp chamber, then this can cause discoloration. So we should assure that there is complete removal of the internal sealer eminence and it should be below CEJ level so that the only restoration is above the enamel. So coming to indirect restoration, the cases we come across regularly. So how do we decide whether we remove it or not? We already spoke about it. It is always better to remove, but sometimes there is cost factors. Sometimes the crown, the marginal integrity is good. There is no reason to remove it. So ultimately, we can decide when can a crown be preserved based on following factors. So it can be margins are clinically sound. They are radiographically also sound. We can create an axis conservatively, especially in anterior teeth. If we know the alignment or the long axis of the tooth, we can do a CBCT and figure it out. So if all these factors are there, we can definitely do it through the crown as well. For posterior teeth, it is difficult. So indications for removal, when there are marginal defects, when there is chipping of porcelain, patient wants a new crown, there can be caries underneath the restoration. Also, it's structurally unstable. There may be a poor previous access, there may be missed canals, something like that. So you make sure that in those cases, you remove the crown and you explain the patient that that's better for them. So regarding metal ceramic crowns, so for removing through metal ceramic crown structure, usually we can use a coarse diamond burr and we can give a composite liner, composite restoration after the retreatment. When we talk about ceramic crowns, we have dedicated burrs for zirconia and lithium disilicate. These are high-speed turbine burrs, and we just need to make sure that the axis cavity is in the center. We need to make sure we know the long axis and it's not going eccentrically. Otherwise, there will be a perforation. And also, we need to inform the patient regarding risk of doing such accesses through the crown. So there is porcelain fracture, there can be debonding in the future. Obviously, there is a compromised seal, and there can be a possible need for replacement later. Now, After doing an access through the crown, you need to assess it as well, whether the coronal seal is unaffected, whether the crown is stable or it is unstable. So in this case, in these cases, you need to also make sure that the temporary restoration that you give in such cases doesn't come out. Otherwise, that affects the prognosis. So you can give a glass ionomer or a composite seal, and then if instability is detected, maybe a polycarbonate crown can be constructed. Now, regarding crown removal. So there are conservative approaches where the crown is intact. So we can use it again as a coronal restoration after retreatment. In semi-conservative methods, we can use that crown, but only as a temporary restoration. That's not a permanent coronal restoration that we can use because there can be chances of future debonding. And in destructive methods is where we fully destroy the crown. This is the easiest way. Now, the selection depends upon the crown material, the type of cement used, etc. Regarding the conservative methods, we have the principle is basically decementation. So we break the seal that is present between the cement and the crown. Uh, so the first method, I'll show you some pictures. This is ritual crown and bridge remover. It's basically a water-soluble thermoplastic resin, and you basically ask the patient to bite on it, and the sudden opening will basically create enough force that it causes the crown to come out. However, it's very strong. There's risk of dislodging even the opposing restoration. So these are other historical methods. There is some matrix bands. If we insert it and then we give a vertical pull, the crowns can come out, especially those which are not bonded properly or bonded with GIC, not with resin cements. Then we can use leverage movement. So we can use a chisel or a Coupland elevator, and with that also, if we apply it on the margin and then we try to give a traction, it can come out. Semi-conservatively, we can try to create a groove buccally. In anterior teeth, we can also create it palatally. So in that case, we can insert the chisel in the groove and then give us like a spreading motion or a traction that will cause it to come out or push out. Make sure you don't give any leverage forces, otherwise you may fracture the tooth. That is the problem with these crown removers, with the conservative ones. So we have specialized forceps and pliers also that can remove crowns. These usually have carborundum on their tips, and then if we gently wiggle the crown with it, it will loosen. We should avoid excessive force. That is the thing. Then we have mechanical extractors or the manual extractors. You must have seen this. This is what we used initially. So this is basically based on the sliding or the drop hammer principle. So basically, there's a weight that you tap and you place the tip on the gingival margin, or if there is a notch in the gingival margin, if some amount of cement, or you can make a dimple also there with the burr, and then you engage it there and then you push the weight and it comes off. So there is risk of patient discomfort. Many times it's painful for the patient also, and there is risk of damage to the root as well. You have pneumatic ones also available. Like this is Corona Flex. This is a system called Kevo. It's also a pneumatic system, automatic system. So basically has a loop that goes around the crown, and then you activate it, and then it gives that sliding hammer wala force. Now the problem is that the force transmitted by such crown removers, it can actually damage or fracture the underlying tooth. Especially if they are post-retained, there is high risk of root fracture also, because the force is not applied along the axis of removal of the crown or the path of insertion. So we have electric crown removers also. They are based on like parachute principles. So you basically insert the wire loop and you switch it on. It gives electric waves, and that causes the cement to debond, and then the crown comes out. Now we come to semi-conservative methods. These basically are based on passive or lever type of instrument like chisels. So this is a classical instrument called Vamkey. It was very um, popularly used actually. So especially for PFM crowns, you can remove the buccal porcelain with a round diamond burr. Then if there is a metal, you use a tungsten carbide burr, and then basically create a groove or a dimple just below the buccal groove of the crown. After this, you insert the key basically, and you give like a wiggle motion, and then that crown will come out. So after removal, you can actually see the buccal side also. So why is it called semi-conservative? Because we can use the same crown as a temporary restoration till we give them a more permanent solution. Now same principle with the metal crown as well for the Vamkey. So they basically have three tips which it comes in and different shapes. However, they are not ideal for resin bonded crowns. It will not get removed because they are highly retentive because of resin cements, and also anterior aesthetic crowns. Also, if crown does not dislodge easily, do not force it. Instead, you section the crown because again, risk of fractures. So this is another system called a metal lift crown removal system. It is also semi-conservative. So basically, it is a self-threading screw mechanism. If we create a occlusal axis, we expose the metal, and then there is a drill which we go through the crown into the root canal, and then we screw the this channel, the metal lift into the channel, and then again we pull it. Axial forces are given, and again the crown will come out. So good thing is that we are forcing along the long axis of the tooth, so there is minimal tooth damage, uh, and we can use it as a provisional restoration later. Again, depth control is critical. We have to gauge the thickness of the metal from the radiographs, otherwise we can gouge the tooth. So then we come on the destructive method, which is sectioning, which is the most predictable. It is the safest actually, because you are not putting any leveraging forces, anything. So basically you section from the buccal side if it's a metal ground with a tungsten carbide burr, and from gingiva to the occlusal side. And then you can insert like a chisel, a flat plastic carrier, or even a two-plane chisel. And then you basically spread a segment, and that causes the segment to come off. Again, as I said before, in anterior restorations, PFM crowns, you can do this palatally, so that then you can use it as a temporary tool. Then coming to bridge removal. So for short span FPDs, we just 3-4 units, we can use that parachute technique with the safe relax one. That wire loop is inserted at the distal abutment, and then we loosen, and then it actually comes off pretty easily. Otherwise, we can section and remove. This is mostly indicated for long span bridges, and we should section each segment individually. We should use a floss as well to prevent aspiration and avoid excessive force, especially in abutments which are cantilevered. So this is the one that I am using actually. This is a crown spreader. You can actually remove in 2-3 seconds both bridges as well as single crowns. So this is basically a wedge-shaped instrument, and it has 3 prongs. So you can actually use the curved side also, the flat side also, and just section the tooth, and then you use this, it works like a chisel only, but then it's very effective. It comes out. It's called a crown spreader. There are other types of crown spreaders as well. You can have 2-prong systems, double-ended, and then the Christensen, which is the classic one. Then next section that we'll discuss regarding is intracanal obstructions. So how do we remove cores, pores, silver cones? So regarding core material, as I already told regarding amalgam, if it extends into the orifices or below the orifices, even composite material can extend such way. So we should not use our rotary burrs there. We can go eccentrically and then gouge the tooth. So ultrasonic tips are indicated here, diamond coated ones. And we should take frequent radiographs and assess uh, uh, that we are going correctly, basically. So regarding the structural risk, not all posts have to be removed. We have to know that what is the type of the post, what is the diameter and the length of the post. Whether we can do a non-surgical treatment orthograde in such tooth. We should know the root length and the root width. How much coronal structure will be present if we remove that post? Will there be appropriate ferrule to give a post again? And then what is the remaining radicular thickness? What kind of cement, if we can know it, if it is a referred case, then maybe we'll know that. Then also cement type will also influence how we remove the post. So usually with ultrasonics, the zinc, phosphate, ZOE, polycarboxylate, epoxy based cements will have easier removal. While if we use the resin based cements, then it will be difficult. Why? Because it's basically forming a hybrid layer. It is going into the dentinal tubules, so they are more retentive. So a long pallor and a wide pose in a thin root will have a high fracture risk. So in such cases, we have to assess whether we should go for orthopedic retreatment or we should try surgical or whether we should extract the tooth. Again, we need to ask following question: is the remaining dentin sufficient? If I remove the pose, will it further critically weaken the root? Is there a suspected VRF? Because with post-retained tooth, this is a common complication. How do we assess it? The pathognomic feature is in advanced lesion is the J-shaped radiolucency or the halo radiolucency that we see. We also have to look for an isolated narrow deep pocket. So all the probing depth across the sulcus would be normal, but there will be one point where your probe will dip, and that is also pathognomic for VRF. And there will be sinuses, but not in the apical position. They'll be closer to the gingival margin, and there can be multiple sinuses as well. So that's a paramarginal fistula. So how do we remove pores? The primary strategy is always ultrasonics. So we need to use a circumferential movement in an anti-clockwise direction, and we should maintain a water spray. And if we don't see a movement 10 to 15 minutes, we should change strategy. I'll tell you what else we can. So ultrasonic reduce required extraction force by 25%. They are that effective. So is the mechanism? They cause microcrack formation in the cement. They cause reduction in the bond strength by interfacial debonding. And then the vibrations propagate in the brittle cement layer and again cause breaking and microcrack formation. So that causes the pores to come out. So there are various tips. These are tips which are present in the woodpecker ultrasound, Dr. Talal's kits. And T6, TD6 is the one that is used for post removals. We have the Startex 4 tips, which we can use for metal post removal. This is a Startex 3 tip that we usually use for fiber post removals. And then we have satellite tips also. Then post removal, we should follow a sequence. First, we should visualize, that is the the coronal portion of the post should be appropriately exposed so first you start with a tungsten carbide burr or a diamond burr to expose the coronal part of the burr very carefully. Then you apply the ultrasonic between the post and the tooth structure, basically in the cement layer. We can use magnification that actually makes the process very easy, microscope or loops even. And then we can use these broad-based tips, we can put it on the post, and basically these ultrasonics in anti-clockwise direction will cause the post to unscrew and it will come out. If ultrasonics don't work, then we go for mechanical kits, which are available for post removal. Or we can also try trephine retrieval, though these are trephines which come in various instrument retrieval kits also, like Masser and very classic kit that we can use. So you can see here, we reduce the coronal portion of the post, and this is the post. Once it is exposed, we use an ultrasonic tip in between, and then we remove it with an counterclockwise motion. So how do we, so the first step is again visualization and access. We should have at least minimally, we should have this in our armamentarium. We should have these burrs. These are called gooseneck burrs. There are many local variants also available now. Ellen burrs, Muntz burrs, and even local variants are available. So these are long shank burrs which we can actually rough around the post. Then any types of ultrasonics which are used for posts, these are all the names that we can use. This is a Stieglitz forceps, very useful once the post is loosened, especially in posterior regions, we can remove it easily. And then again, the post retrieval tip by satellite. So these are other tips. And this diagram, you can see that we trough around the post and then we use an ultrasonic, it comes out very easily. Some clinical picture. Yeah. So mechanical post removal kits, we have a number of them actually. Classic kits, they use basically that drop hammer principle, but we should use them only when ultrasonics have failed, long posts and such. And then trephine systems, we have screw posts. So if we have those metal posts, very long back threaded posts were used. So these posts basically came with a kit which already had a retrieval wrench. So these wrenches, dentatus and radix anchor, so that we can just use and it unscrews it. And then fiber post removal will come on that also. So regarding screwed metal posts, same principle. We expose the head here and then we put the ultrasonic in the cement layer or we move it counterclockwise. We can actually even touch the post and it unscrews pretty easily. We can also use K files which are ultrasonically activated, those ones also, and even hemostatic pliers with indirect ultrasonic activation. So these are the wrenches. So if you have a threaded metal post, once we expose it coronally, these wrenches already come. If you use the same post and then these wrenches are present, you can use them also to remove it. And good thing is this is just GIC because if the resin cement goes into those grooves, it will be very difficult to remove. So regarding cast posts, we have already seen regarding prefabricated metal posts. This is regarding cast posts. Cast post removal, you basically you remove the crown, expose the basic core, and then you can make a notch with a burr or even with an ultrasonic, and then you engage the ultrasonic in that notch, and then it will be pushed out. That is how we remove a cast post. So only issue with this is there can be risk of root fracture because it is it is a custom fit. So it adapts to the canal. A clinical picture, again, these are some of the cases. So they use a sectioning method to remove the crown. And you can see the groove even extending into the cast post. And into the same groove here, they put the ultrasonic tip. And again, it comes out easily. So basically, it debonds and comes out. Here they have put the ultrasonic tip on the cement line here. And then again, they have activated it and then it has debonded. So these are mechanical kits only when ultrasonics fail, you can try and use them. Basically come with a screw tap system. So here externally you tap it once you attach the trephine or the screw system here. And then it will come off. This is the Gonan, which is a very universal kit. Then there is just this VAMAC system, which is a different type of force retrieval system. Here we cut the crown in such a way that we put the forcep here and then we activate it and that removes it. So the good thing about is it has, because it doesn't use like a drop hammer principle like in Gonan. So there is reduced risk of fracture of the root. Then if you have split pin post, you can just section it into 3 or 4 chunks and then individually remove it with ultrasonics. Then regarding fiber post removal, which are the most difficult in terms of post, because they are bonded to the dentin with adhesive resin, and then the resin has infiltrated into dentinal tubules. And glass fiber, carbon fiber posts are sometimes radiolucent also, and they have similar color to dentin as well. So there is risk of deviation and perforation. So in these cases, we don't use the debonding principle. We don't rough in the cement and the post line. We actually go through the post to disintegrate the fibers. So these are the burrs that we can use, those gooseneck round long shank burrs. We can use piso drills, we can use GG drills also, and these are dedicated post drills that we use with different, even Colteen has one. So that also we can use to disintegrate the post basically. So we should, how to differentiate between dentin and fiber post, or between the tooth and the post. It usually leaves a dark marks on the composite when we use an ultrasonic tip, and that won't be there in the tooth structure. So this is the removal strategy. Basically, if there is a post here, access cavity, you expose the coronal portion, and this is the gooseneck. Basically, we create a pilot channel. So we go through the post, and then once we have created a pilot channel, we can even use a GG or a piezo drill, and basically we remove it in chunks pieces. And we should take periodic radiographs so that we know we are going correct. So fiber post removal, we can just see some clinical pictures here. This is a fiber post. We can see the black dust coming. This is characteristic of like carbon fiber post. So this dust means we are going through the post. So then we can see once we have reached on periodic radiographs, we can see the GP also, and then we can retreat it normally. Again, we create a pilot channel through it with a gooseneck burr, and then with a piezo drill, we can remove it. Then access refinement. So before proceeding with the retreatment with removal of GP, we should refine our access. There may be shoulders present which may basically prevent our files from going in a straight line, and then this can cause further complication. It can lead to instrument separation as well. So we should remove the shoulders either with the safe and diamond burrs or carbide burrs, or like those endozes, or we can use even Gates Glidden drills. So we should have a knowledge of the canal anatomy as well. What we are looking at is in molars, missed canals. Usually, if we see a radiolucency, MB2 is most of the times missing. So I'll explain to you some tips and tricks where we can look for it. And in mandibles anteriors, most of the time there is split. So that's why those treatments also fail and we have to go retreatment. So root canal filling materials. So this depends upon what kind of material is there. Usually GP is there. If what kind of sealer they have used, whether it is a ZOE based sealer or eugenol. So these are actually simple to complex depending upon whether they are hard or soft. Then if we look at gutta percha is simple to remove actually. And then one second. Yeah. And then if you have AH plus or resin based sealers, they are actually the most difficult to remove. Even mineral based sealers like bioceramics are difficult to remove because they penetrate into the dentinal tubules. They can go into the lateral canals as well. Then silver cones also, they are at the risk of fracture, so difficult to remove. So ultimately, our technique will be based on what type of instrument we use and what type of solvent also. So how do we actually test what type of material is there? Most of the times it is GP, but we can use a DG16 and also see a small drop of solvent we can place, and we can actually understand what kind of sealer it is. So there are various solvents that are available in the market. Research has shown that xylene has having the highest dissolving efficiency. We can use essential oils, they have lower toxicity, but their dissolving ability then comes down. Chloroform is again most effective, but then it is very toxic also, but can be used as an adjunct. And then solvents do not actually affect apex locator accuracy. So this is something that often comes up. Then, but you should avoid excess solvent. A drop or two is enough because it can soften the GP, it can smear on the walls. It can penetrate into the dentinal tubules, and then it will be more difficult to clean. So silver cones first we'll talk about. So there is one method here where they have exposed the silver cones very nicely after removing the core, and then they use a hemostatic forceps, or they can also use a Stieglitz. Basically, you grasp the cone, and then you use those drop hammer crown removers that I showed. You put it here on the grass, and then this is basically requires four hands. It's a four-handed dentistry procedure. And then once you do a drop hammer, the silver cone basically disengages and then it comes out. Another is using ultrasonics. So for exposing the sealer, you can use actually a drop of solvent, and around the space between the silver cones and the orifice, there will be spaces. In that, you can put solvent through a K file. So that actually removes the sealer around the cone. And once you expose it, you take a forceps again, engage it, and use ultrasonically activate it, and then it comes out as a whole. If it fractures, we treat it like any instrument separation. We have to rough around it and then remove with the loop or something, depending upon the where it has fractured. Now there are different types of pastes and sealers. They can be soft consistency, spongy, or hard. So generally, most of them are soft. Paste means like the calcium hydroxide paste that we use, and Metapex, all of those kinds. So we usually with irrigation they come off, and then we can use sonic irrigation, and that will remove all the paste from the fins and the isthmuses also. Now, if it is a hard paste, then we might have to use ultrasonics. So there are various solvents available for paste. So we have Endosolve E, which is used for eugenol ZOE based sealers and cements. Then we have Endosolve R, which we can use for like AH26, AH plus and all, the resin based materials. And then chloroform as an adjunct. So again, removing with solvents is challenging, especially in the apical region and in the lateral anatomy. If you have Metapex, then in the coronal portion, you can remove mechanically. You can use endosonic. This is an endosonic file. Sonic irrigation you can use with even with irrigants. And then there are specific even tips available by Action, and these are U files. These are sonic files that you can use to remove the paste from the balls. Then we'll come to gutta perca removal fast. And this is the easiest way is, so it depends upon the technique. Now, single cone, if they're used as an obturation, you can see spaces between the orifice and the cone. So basically, this is where you engage with the H file. And this is the easiest method. You can just remove it in a single piece. So you put it anti-clockwise and then give a pull, good coronal traction. But if you have, suppose, overextending GP, which is extending beyond the apex, then sometimes what happens if you use a very large H file, the GP will cut off at the apex. So in that case, what we can do is we can use a smaller size H file, and then we can instrument maybe little and engage it, and then we give it a extraction. We should avoid cutting that segment of GP with larger H files. So if you use a smaller H file, it will actually, you will be able to pull it once you engage it. You can confirm radiographically and then pull it off. Then if they have used a condensed type of method, a thermoplastic method, then you can see two zones you can divide the root. In the red zone, you can use mechanical methods. You can use solvents to remove it with irrigation, with sonic activated irrigation, or you can use even ultrasonics, all of that. In the apical region, don't use solvents. So here you use only hand files or small size H files. So solvent used for GP, these are the solvents that are used. Cutter solve is what comes in the market also. And we have to remove it in small increments for condensed GP. And we should see with the paper point that will come later. So anyway, this is a case where they have an access cavity where they have not fully exposed the pulp chamber. They have done a root canal through the pulp horns. So again, first step is to de-roof it completely. Then you can use rotary instruments, also retreatment files to remove the GP, but retreatment files only should be used till the middle third, not in the apical region. Then you can still see tags of GP. This you can remove with an H file. And if still some GP is present on the walls, then you can use some solvents. So this is with the solvent method. So mechanical, if the bulk of the removal you should do with a file, and on the walls, if there is, because this is a condensed GP, they'll be on the walls, you can use solvent. And then the more amount of H file you use, you will see the amount of GP, the dissolved GP that is coming out is lesser and lesser. And then you confirm with the paper point in the apical region. These are the retreatment files. So this is by Dentsply, their pro-taper universal system. It comes with 3 files, D1, D2, and D3. D1 we have to use in coronal third, middle, and then this goes, we can use it a little beyond middle third, but not till the apical. That we have to do with H files. And then this is also there. It's a profile system. So the thing about these files is they have active tips. So they are very efficient for removal of GP. You just use them with the, not, you use them passively. You don't actively push them. You can use them anti-clockwise also, but passively, and the GP unscrews and comes out, especially if it's a single cone, it will easily come out. So these are the pictures you can see. So this is the D1 file, that this system. So they have used it in the first, we use a crown down technique. So first they use it coronally, the D1. D2, they go till the level of the middle third junction of middle and apical. And then they go little above the apical third. And then finally, you can see the working line, they still GP at the apical third. So for that, you should use a H file, or rather a small K file also. Engage the JP and then take up. Then coming to challenges during instrumentation, quickly we'll do this. Negotiating untreated part of the canal. So you will see retreatment cases where there is debris and obstructions here. It could be a ledge also. But suppose this is the case, then you use retreatment files till here, till the level you can remove the GP. Then you use a small K file, a 10 number or 8 number, and you try to find a catch. So once you find that catch, then you go for bigger number K files, and like that you have to prepare the tooth. And then you can ultimately use rotary files till the apex. So in case of hard cements, now once we remove a post, this is a situation where they have removed the post, but there is some invisible thing that is present between the post and the GP, if you can see. So that radiolucency. So that they are not able to get to the GP. So basically we have to use ultrasonics here, ultrasonic tips, or we can use these burrs, but I'd prefer like pro ultra tips here. And you can use these irrigators, Stropco ones or modified ones. Then you can actually nicely see it under microscope also, where you are going and what is the inside also, you can visualize nicely. So you have untreated and missed canals also. So especially in mandibular molars, incisors, you will have splits. So how do you actually negotiate them? You go till the tip. You prepare the canal, one canal properly, and then you look with a smaller size K file, you look along the wall for the split. Once you get that catch, or also you can use any rotary file to make a notch if you get that catch. Once you have that notch, basically you have formed a ledge here, a nitrogenic ledge. So whenever you insert an instrument, a rotary instrument again, it will go along it, and this will prepare your split. So this is actually the most common cause of failure is missed root canals. So these are some methods for MB2 actually, or any missed canal. You can actually look at the pulpal floor. Usually MB2 is hidden behind beneath a dentin shelf. So you have to remove that shelf and then see. You can use micro openers. They are like DG16 by Dentsply uh, for looking for a catch. You can use dyes also, methylene blue and all. So you will get a nice indication. Champagne bubble test is the classic test. Sodium hypoflooded into the cavity and then we see bubbling. You can understand there is an orifice there. And then with explorer, again, pressure. So there's something called as a red line test where you see a bleeding. So you can make out that there is a canal there or along there. So you just look for it there. You can dry it and also look. Then when when you trough that dentin shelf, which is present covering the MB2, you use it with dry troughing only you do. So it will create white dust, the dentin debris. This will basically form a line. I'll show you a video. So this is my case where you can see I troughed it. It formed a, one second. Yeah. So you can see this white line here. So the orifice is lying here only. You use a small size K file to scout. you confirm the scout, and then you negotiate and prepare the canal. So in this case, actually, there was an overextended GP as well. So that I removed with an H file only, like the method I told about earlier. Then missed canals again. So in this case, what was wrong? Anyway, the obturation is short, but this was also a case of aberrant anatomy. We took a CBCT because if you can see after opening the axis, there's a lot of debris, secondary caries, and everything. And also the axis looks eccentric. It doesn't follow the normal anatomy. So on taking the CBCT, we can see that there is a additional MB2, or we can say a mesiopalatal canal also. And then we prepare it, and then that is how we do. And then here again, mesial canals were not retreated. So they were just lying at a deeper level actually. So I troughed with ultrasonics, found them with a white line, scouted where they are, and then easily I can find the MB2 also, and they were done. They were just lying at a deeper level. Even CBCT in these cases will help. So you can save teeth like this. Actually not calcified. They just needed to find it. So this is a kind of case. So most of the palatal roots, usually they don't have a split, but many a times they have, and you can identify with a lateral radiolucency. I took a Insta poll actually. I asked them, how do you actually go look for a split in a palatal canal, or you identify from a radiograph? So you will see in the pre-op, there is sudden, you can see a disappearance. There's a fast break appearance that we see. That means there might be a split. Usually the GP will be short also. And lateral radiolucency, that means there is a lateral canal or a split. So for these cases, again, I scouted it and then prepared the canal. And then I just use a sealer. This is just a sealer that is going after preparing. I didn't put an additional GP, I laterally compacted the palatal canal. Also, if the palatal rule, you have a sharp bend towards the distal side, possibly there is a deep split here. This is also given in literature. Instrument retrievals, I'll not go in detail, but some of the cases, you basically use a GG drill. You cut it with a diamond burr here in the middle, and it gives a modified this. So basically, you prepare a stage or a flat surface around the instrument. So for example, if this is the instrument, you prepare a flat this thing. So now once that is there, you can engage your ultrasonic and basically trough 1 to 2 mm to expose the instrument further. Once you expose it, you can either use such files, these are like a endosonic file only, or ultrasonic file, and you move it. If you have a microscope, it's very actually easier. You can see exactly where to put the tip once, because it's a triangular cross section of the rotary file. So that you can use an ultrasonic to disengage it, or also you can use a loop method, a loop technique to remove it. So this was actually a pedo patient. Crown was also fairly easily removed. It's a stainless steel crown. And then we gave an endolink, or a kind of endo crown we give. Instrument retrievals, again, most of them are done with the loop technique because they are in the middle third. Ultrasonics are too aggressive. They will cause gouging, perforations, strip perforations. And even this I did. This I wanted to show you a modified micro tube technique. Unfortunately, we have less time, otherwise I would have explained this technique to you. Then regarding the instrument retrieval, actually this was my thesis. I developed a loop device. It's a patented device with a dual locking system. And the articles are there in Saudi Endodontic Journal. You can go through those articles. They are comparing loop versus ultrasonic fractured instrument retrieval, and how does operator experience affect it. Actually, loop, the learning curve is over time is lesser only. So you just need to practice it, and then it becomes, if you have appropriate armamentarium like magnification and everything, it's easier. And time efficiency also. Ultrasonics takes a lot of time. It's time consuming. Even for posts, it is time consuming. Now, aberrant anatomy, another case for failure of endo. So they didn't obturate it properly. There was basically a C-shaped canal. and then we took a CBCT, and then we did the obturation. This one is a lower molar, again with a single C-shaped canal. We used a downpack and backfill technique here. Then perforation repair is the second most common reason for failure. Perforation, not repair. And then what are the signs actually? If there'll be sudden bleeding from the canal, there'll be pain up to the patient. You can check with an apex locator. It will give apex. It will give variable reading, and then it will just give apex. And then radiographically you can check. So management depends upon the site of perforation, whether it is in the coronal third, it has the best prognosis. If it's in the middle third, then we need to surgically expose the site and then put bioceramic or MTA material there. And if it is in the apical third, then or it's a strip perforation, it is difficult to repair. We can then decide for hemisection, and if the patient is very keen on saving the tooth, like bicuspidization and those techniques. Then this is a perforation repair retreatment case. So this is the perforation. I exposed the canals, did a repair. So first you repair the perforation, and then in the next visit I did the obturation. Then ledge formation, another cause of failure. So it causes short obturation. For such also, you have to pre-curve the small size hand file, look for a catch. These, it comes with practice. It will be all such cases are difficult only, but with practice, you'll be able to find a catch, and then you prepare with the rotary here. And then last section is disinfection and medicaments. So there are numerous advancements in disinfection protocols. We have new techniques, new irrigants, but nothing beats hypo. That is still the gold standard. So the protocol I follow is I use copious rubber isolation, copious hypo during instrumentation. Then I use EDTA to remove the smear layer, and then a final rinse with hypo. And then for retreatments, we can go for intracanal medicament and obturated in the next visit. That is better. Otherwise, depends upon the condition of the canal. We can also complete it in single visit. Now there are various methods here. Lasers have come into play. We have photodynamic activation, pips and sweeps. This is a pad endotip by Dentotex. And then the basic principle is use safe-ended needle, side-vented needles, and do not bind it. Use it passively. And then you can manually dynamic irrigation also you can use. And at least you prepare till 25 size apically, so that will cause better irrigation to the apex. So single versus multi-visit and retreatment. So if it's regarding this, what is the actual criteria? That's two. So there should be absence of acute symptoms. Patient should not have any pain, even if there is a radiolucency. They should not have like pain. They should not be tenderness on percussion. So acute symptoms should not be there. There should be dry canals is the second criteria. So if there is pus discharge or anything, you're not able to get a dry canal with the paper point once you check, then again you have to go for a multi-visit. But if you have both of these two criteria, there's no acute symptom and it's a dry canal, you can go for a single visit retreatment. Enough articles now that give good percentage of success for them. Surgical endodontics, if they are only indicated when it is impractical to carry out conventional root canal treatment. There is a very long wide post in a narrow root, or in where the non-surgical retreatment has failed multiple times. Then you can try this. And apical surgery, other than these retrograde filling and retrograde preparation, I'm not covering this in the scope of the seminar, but you can also use intentional. So in this case, the file was extending beyond the apex. It was actually in the socket. So we did a root canal treatment first, and then removed the tooth, we used a microscope to remove this file in the socket. We actually, with a loop only, we removed it. And then we gave a splint. So this patient is actually under follow-up. We'll see how it goes. So in conclusion, I am proposing this protocol framework. So just remember it with a retreat acronym. You reassess your diagnosis first, whether it's a persistent infection. You evaluate the restorability of the tooth, whether it will have a long-term outcome or no. And you assess with radiographs, at least multiple angle radiographs or CBCT. And then you enhance the access, make a straight line entry into the orifice, locate missed canals. Then take out previous filling materials, post, silver cones, gutta perca paste, and ultrasonics are your friend here. Then re-establish the canal patency. So negotiate till working length. You regain the patency there, and if possible, correct the ledges. Then E is to eliminate the infection. You scope your sodium hypo EDTA for removal of smell layer. Irrigant activation in retreatment actually increases the outcome. So it has more success if you use a activated irrigation protocol. So intracanal medicament we can use when indicated. We can give calcium hydroxide. Um, if there is persistent pathology, we can try leather mix also, or even tap triple antibiotic paste and all that. Assess canal condition. So if it is a dry symptom-free canal, you can go for obturation. You can reevaluate the working length and anatomy in the obturation visit also, and then you again irrigate it nicely. And then a 3D seal or three-dimensional obturation is also necessary. And the part that I didn't cover, adequate coronal restoration later. So even if we do a good retreatment, everything, it may still fail if there is micro leakage. So we need to make sure that we give a good core and then a crown. So these are some of the books. If you want, you can take a picture. These are good books on retreatment, some of the classic books, and they give very detailed and they cover all the aspects, even surgical endodontics. One of the articles which are very helpful is a recent systematic review of randomized control trials. And here they have shown that non-surgical retreatments actually have about 80% success rate. So it's a very successful procedure. A patient does not have to go for extraction. If we can save the tooth, we should try. Thank you all for listening, and please feel free to DM me. These are my contact details. Thank you. Dr. Juna, I think you can. Hello.
Hello.
Yes, Dr. Juna. Hello.
Hello.
Any questions
Yes.
anybody has, or we don't have time for that. I think we have extended
Okay,
15
I think we
minutes.
can wind up, right?
Yeah.
Okay.
Any questions,
So
please feel free to DM me. Okay.
thank you so much, ma'am. Thank you for Thank you so much for that incredibly insightful and clinical rich session on simplifying complex retreatment cases. Your practical tips, step by step explanation, and real world case discussion have certainly enhanced our understanding and confidence in managing challenging endodontic treatments. I'm sure all of us are walking away with valuable take home messages, and we can immediately implement it in our clinical practice. On behalf of IATP, I extend our heartfelt gratitude for your time, effort, and willingness to share your expertise with us.
Thank you.
And
Thank you
dear
for the.
doctors, dear doctors, thank you for your attentive participation and engaging presence throughout the webinar. Your commitment to continuous learning is truly commendable. We request you all to follow Dr. Tanushree Saxena ma'am's on Instagram to explore more of her clinical work. To stay updated about our upcoming webinars and workshops, please visit www.iadp.org and follow us on Instagram and Facebook. If you missed any of our previous sessions, they are available on our YouTube channel, and we would greatly appreciate your subscription and support. Once again, thank you all for being a part of this academic journey. Have a wonderful night and keep learning, keep growing. Good night all. Good night, ma'am.
Good night.